Assalamu alaikum and a very good afternoon, everybody. I feel privileged to have this opportunity to talk in front of this August gathering, though it is difficult for me because after a very good presentation by Dr. Devika, and the time is very short, so I will run a bit fast. So let me start with a case scenario. A 55 years old lady presented to our hospital with the complaints of shortness of breath for last 5 years, which was more marked for last 1 month, hemoptysis, palpitation for some duration. On query, patient gave history of rheumatic fever in her childhood. Clinical findings revealed that pulse was 100 beats per minute, irregularly irregular. Slide. So clinical findings revealed that pulse was 100 beats per minute, irregularly irregular. BP was 100/60. First and second heart sounds were of variable intensity. There was a pansystolic murmur over the mitral area, which radius towards the left axilla, and there was also a mid-diastolic murmur. There was bilateral basal crackles present. ECG revealed that there was atrial fibrillation with fast ventricular rate, incomplete RBB, and right axis deviation. XHS revealed there was cardiomegaly with LV-type apex, double right heart border and widening of carina, straight left heart border. Then we did the echocardiogram. Here you can see the parasternal longis view showing the thickened mitral valve leaflets, diastolic doming of AML, and the chordae are thickened, you can see the distal part of the chordae, there is chordal fusion. Short X-ray showing the reduced orifice, MV orifice is elliptical, both commissures are fused, and there is calcification at the posterior commissure. Here is the planimetry showing that the valve area is about 0.8 centimeters square. The color flow imaging showed that there is more than moderate MR. Here, eccentric MR in apical 4-chamber view. And spectral Doppler indicate that there is a mean gradient 14 millimeter mercury. PSP, by adding RA pressure to tricuspid regurgitant PPG, we found there was severe pulmonary hypertension. We measured the annulus for the patient and measured the TAPC as the indicator of RV function. And then the total echo report that it is chronic rheumatic heart disease, severe MS with moderate to severe MR, dilated left atrium. There was mild to moderate TR with severe PH, hypertrophic RV with moderate to severe RV systolic dysfunction, and there was good LV systolic function. So now we focus that the patient has severe MS with more than moderate MR. So what should you do? Should you refer the patient to interventionist or to the cardiac surgeons? Severe MS with more than moderate or moderate MR, we should refer the patient to cardiac surgeons. So how we assess the severity? We follow the 2008 guideline for assessment of MS severity. According to this guideline, when area is less than 1 centimeter square, it is considered severe, and mean gradient more than 10, and PSP more than 50 millimeter mercury are the supporting findings for severe MS. According to the 2020 ACC and AHA guideline, valve area less than 1.5 is considered severe, and less than 1 is considered very severe MS. Other hemodynamic parameters are same as 2008 guideline. So when stress echocardiography is indicated to unmask symptoms of NVA when it is less than 1.5 centimeter square, and when there is no or doubtful complaints, and when there is discrepancy between resting Doppler and clinical findings. So for PTMC, that is to refer the patient to for interventionist, Wilkins score is the most widely used. Wilkins score look for the mobility and thickening of the AML, chordal involvement and calcification, and range from 4 to 16. But there are limitations of Wilkins score because it does not include the commissural calcification. So in general, Wilkins score less than 8 to 9 with more than moderate MR and without any commissural calcification should refer to the interventionist for PTMC. So what are the contraindication for PTMC? MVL more than 1.5 centimeter square and absence of commissural fusion. In fact, for this 2 point, there is no intervention needed. Other contraindication, the LA thrombus, more than mild mitral regurgitation, severe bicommissural calcification, severe concomitant other valve disease, and concomitant coronary artery disease requiring bypass surgery, patient should refer to cardiac surgeon. So here the example of thrombus contraindication, and where we can see the bicommissural calcification and calcification within the valve orifice. In these cases, the patient should refer to cardiac surgeon. TE should perform before PTMC to exclude LA thrombus. And 3D echo is accurate for accurate evaluation of mitral valve anatomy, especially in calcified mitral valve cases. So this is an echo view of a patient suitable for PTMC. We can see the valve is pliable and the cordia are thickened, but there is no caudal fusion. MR and AR are just mild. Short X-ray show that there is commissure fusion, but no calcification, and the LA appendage is clear. MR is mild, and Doppler gradient, mean gradient, 12 millimeter. This patient severe MS without commissure calcification, and MR is mild, AR is mild. So this patient can be referred to interventionist for PTMC. So mitral valve stenosis and the likelihood of reconstruction. Pliable leaflet with minimal subvalvular lesion, reconstruction is feasible. Rigid leaflets with minimal, probably feasible, but distillation when there is severe subvalvular involvement, reconstruction is not feasible. So mitral stenosis, that is rheumatic MS with contraindication of PTMC, and all hemodynamically significant congenital MS should be referred to cardiac surgeons. The congenital MS which we see in our daily practice, the more common are mitral valve, supramitral valve membrane, and parachute mitral valve. Here is an example of supravalve mitral membrane, and here we can see the parachute mitral valve as all the cordia are converged to a single papillary muscle. Here we can see subcostal view showing that all the cordia are converged to a single papillary muscle, resulting in severe MS. This patient should go to cardiac surgeon, not to the interventionist. Now I focus on mitral regurgitation. So what are the clinical parameters should consider for intervention in MR? When the mitral regurgitation is severe and patient has symptoms, he or she should go to the cardiac surgeon. In case of asymptomatic MR, but when there is LV systolic dysfunction or LV end-systolic dimension more than 40, he or she should go to cardiac surgeon. And in case of asymptomatic severe MR, if there is progressive increase in LV size by 3 serial echocardiography, he should go to intervention. He or she should go to intervention. So what is the role of echocardiography? The role of imaging is twofold: to determine the severity of MR and to determine the etiology of the disease. T transthoracic is recommended as the first line imaging modality. T is advocated when TT is non-diagnostic value. 3DT or TT is reasonable to provide additional information in patient with complex mitral valve lesions. Especially T is recommended in the operating room when a mitral valve surgery is performed, especially during mitral valve repair. So the 2D echo parameters that should be studied in patient with MR: evaluation of valve morphology and etiology, size of the invanulus, LA and LV dimension, evaluation of RA and RV size, LV and RV systolic function, and assessment of regional valve motion abnormality of LV and RV. Assessment of severity of MR comprises of emergent area evaluation, measurement of vena contractor width, volumetric method for calculation of mitral regurgitation volume, PISA method for calculation of ERO, MR regurgitation volume, MR regurgitation fraction, and measurement of PA pressure. PISA method already shown by Dr. Devika, so I will not go through it. Here the diagrammatic representation of tracing of emergent area and calculation of the ratio between the emergent area and the LA area. When the ratio is less than 20%, it is considered mild, and more than 40% is severe. This is the schematic representation of MR by jet area ranging from mild to severe. The vena contractor of MR jet measurement is practically important because it is less influenced by the eccentricity of the MR jet, and here is a schematic representation how we measure the vena contractor, narrowest portion of the MR jet downstream from the orifice. When it is less than 3 cm, it is considered mild. When it is equal to or more than 7, then it is considered severe. So for day-to-day clinical practice, for severity of MR, we consider color Doppler jet area, vena contractor width, and enlargement of LV IDD and LV in systolic dimension. So other color Doppler parameter for MR severity assessment, I have already mentioned the volumetric method and the PISA method. So quantitative assessment, when the regurgitant volume is more than 60 ml, then it is considered severe. Regurgitant fraction equal to or more than 50 severe. Regurgitant orifice area more than 0.40 centimeter square is considered severe. And additional essential criteria, the LA and LV should be enlarged. So classification of mitral regurgitation, when the morphology is abnormal, then it is considered primary mitral MR, and when the mitral valve morphology is normal, but it is caused by other causes, then it is considered as secondary MR. And according to the mechanism, the Carpenter's classification according to the leaflet motion, type 1 normal leaflet motion, type 2 excessive leaflet motion, and type 3 restrictive leaflet motion. Here is the schematic representation of mechanism for MR. We can see that in case of type 1, there is annular dilatation or perforation. Type 2, there may be prolapse or flail. And in type 3, there is thickening and fusion of the leaflets and chorda, and there may be LV or LA dilatation. This mechanism we must know because this helps in the valve repair. So when stress echocardiography is indicated for immediate risk stratification and to guide the timing of valve surgery. Mitral valve repair is the recommended treatment for degenerative mitral valve disease. MV prolapse or floppy MV syndrome is caused by myxomatous degeneration, resulting in MR due to leaflet thickening and redundancy, chordal elongation or rupture, papillary muscle elongation, and annular dilatation. So during repair, all these factors should be corrected by the surgeon to maintain the normally functioning mitral leaflet. And calcification of the mitral annulus often makes repair challenging, and it is best to avoid the repair in patient with a calcific mitral valve. Segmental analysis of mitral valve disease is recommended for as it allows the precise localization of the leaflet dysfunction. Valve morphology, that is valves, are divided into 8 segments using the escallops of posterior leaflet as reference, 3 escallops of PML, 3 segments of AML, 2 commissure of anterolateral commissure and posterior medial commissure. Thus, 8 segments of the mitral valve are extensively evaluated for valve repair suitability. Here is a schematic representation of the different segments and escallops and the commissures of the mitral valve. So the goal of the mitral valve repair is to re-establish anatomically normal mitral geometry, dimensions, and function. Requirements for normally functioning mitral valve leaflet should be fully mobile. The free edge of the 2 leaflets are well positioned 5 to 10 millimeter below the plane of the orifice, and there should be large surface of coaptation. And this should be checked by paraoperative transesophageal echocardiography. So echo measurement that are useful for the surgeon to reconstruct the mitral valve, the ratio of anteromedial dimension of the annulus and the height of the anterior leaflet is normally less than 1.3. So surgeon should maintain this length. And the height of the A2, which is a good indicator of the size of the ring to be selected. Using the transgastric longitudinal view, the number, shape, and position of the papillary muscles are assessed. Here is the parietal analysis view showing how we measure the coaptation length and coaptation depth to help the surgeon for mitral valve repair. So during repair, the post-MV repair length of coaptation is very important. Ideally, the line of coaptation should be 4 to 10 millimeter deep. If it is less than 4 millimeter, further correction should be performed. If it is more than 10 millimeter, the patient may be at risk for developing systolic anterior motion of the mitral valve. So this should be checked paraoperatively by transesophageal echocardiography. So probability of successful MV repair in organic MR based on echo findings, when there is degenerative or secondary lesion just localized to mitral valve and annular dilatation is mild to moderate, then repair is feasible. When there is extensive disease involving more than 3 scallops, and though calcification is localized, but repair is difficult. And other extensive diseases causing extensive mitral valve leaflet involved, then feasibility of repair is unlikely. Here I want to share some of our cases where repair is feasible. Here is the prolapse of anteromitral leaflet, emergent caused by the AML prolapse. Here the flail of the P2 segment of PML, flail of the P2 segment of PML. Here the emergent caused by the flail PML. Here the 3D echo showing the prolapse of the P2 segment of PML. Here the flail PML and showed by transesophageal 3D echo and the corresponding severe emergent by PISA method. Here the 3D echo showing the true cleft of the AML. 3D TE showing the orientation of the cleft is towards the aorta. It helps for the surgeon to repair the valve. Here there is a vegetation at the axial surface of AML causing perforation of the AML. If vegetation size is small, then repair is possible with a steel hand. Here we can see the vegetation and the perforation. The emergent moves to the perforation and vegetation on the two sides. Vegetation perforation, and incidentally we can find the mitral valve tumors. There may be myxoma or papillary fibrillostoma, or sometimes occasional blood cysts may impinge the mitral valve leaflet, causing mitral regurgitation. Whether they should need intervention depend on the hemodynamic consequences of the valve. So the take-home message, mitral stenosis should be referred to the intervention for PTMC when there is a pliable AML without severe subvalvular involvement with no commissure calcification and less than moderate MR. And when it should be referred to cardiac surgeons, all hemodynamically significant rheumatic MS not suitable for PTMC, all congenital and other MS patients, and whether OMC, reconstruction or valve replacement should be done, this will be decided by the anatomy, morphology and the associated condition. And for mitral regurgitation, when we should refer the patient to interventionists, that is for transcatheter edge-to-edge repair. If the surgical risk is too high and morbidity is high, mitral valve anatomy is favorable for the repair procedure, and patient's life expectancy is at least 1 year. And when we will refer all other cardiac MR cases, all other mitral regurgitation cases should be recommended for surgery. And this, whether the surgery would be repair or replacement will be depends on the mitral valve anatomy. Thank you for your kind attention.
Thank you, madam. Thank you very much for your nice presentation. If you have got any question regarding this presentation, you can ask.
Yes.
Dr. Govinda Kantipal.
Thank you, madam, for your spectacular and very much informative presentation. I have a question. When mitral stenosis with mitral regurgitation, in that case, how can you measure mitral valve area? Which method is appropriate? And in case of atrial fibrillation, mitral stenosis with atrial fibrillation, in which method is preferable? But in case of mitral leaflet calcification, planimetry is very much difficult to measure. And also coaptation line, measurement of the coaptation line. My 3 questions. Thank you, madam.
Planimetry is the ideal for assessment of mitral valve severity when there is calcified mitral valve leaflets. Calcified mitral valve leaflets is very difficult by 2D transthoracic echo. Then 3D echo. 3D echo is ideal for calculation of area of the calcified mitral valve. And for AF, that we have to take planimetry of the 5 Bs and take the average. And for measuring the coaptation length, we can see, I have shown, okay, I will go, I will show you.
Okay.
There is one slide because of